Hello everyone, this is Dr. Ismail and today we are going to start our simplified version of Bailey and Lowe topics. So starting with the first chapter, that is metabolic response to tissue injury. So what is this metabolic response to tissue injury? So basically whenever we are operating to the patient or whenever we are getting any patients in the trauma, patient will be having some sort of injury, either it is iatrogenic or it is due to trauma induced. So whenever there is any tissue injury, body will elicit some kind of inflammatory reaction to it, so that it will prevent the further injury and it will repair the injury. So this is the procedure we are going to study today. So basically what is this metabolic response to injury? The definition is the metabolic response to injury is a coordinated neuroendocrine and inflammatory response triggered by either trauma, surgery, burns or sepsis. So its primary purpose is to limit the tissue damage, eliminate the pathogens and promote healing and wound recovery. So this is the definition of our metabolic response to injury. So what are the functions of this metabolic response to injury? Is basically it limits the further tissue damage and also it maintains the tissue perfusion and vital organs during the stages of sepsis and shock, and basically it mobilizes the energy substrate which are glucose, fatty acids, amino acids for faster wound healing, and also it supports the immune defense against infection. But this is also having some kind of complication, such as whenever there is an exaggerated response, it leads to systemic inflammatory response syndrome, and also patient will be having the state of immunosuppression. Patient will land into the multi-organ dysfunction and patient will land into the septic shock, and ultimately patient will land into the death. So this is the complication of our over exaggerated tissue injury or inflammation. So basically this is the graph showing our basic resting metabolic rate. So whenever there is a normal resting metabolic rate, so body is acting normally, but during starvation the graph is showing that our resting metabolic rate, initially it will decrease and it will go into the negative balance. But whenever the patient body is having minor trauma or any kind of major trauma or any kind of surgery, if there is a minor trauma, the metabolic response will increases. If there is a major trauma, metabolic response increases further. So this is the graph showing our resting metabolic rate, which is the body's capacity in the daily activities. So coming to our next aspect, that is our nitrogen excretion and the per day of rate of excretion of nitrogen. So basically whenever we are consuming any kind of protein products, it is going into metabolism and finally nitrogen is excreting in the urine as ammonia. So whenever there are any kind of minor trauma or any kind of major trauma or any kind of injury, the nitrogen excretion per day it will increases, and we can see in this graph that it can reach up to 20 gram of nitrogen excretion per day, and the normal nitrogen excretion per day is 10 to 14 gram, and which can increase in the cases of sepsis or any kind of major injury. That is also one of the MCQ point, that is our nitrogen excretion can increase up to 25 gram per day. That is the severe wasting of our proteins in the body. So coming to our next slide, so there are basically two phases in the metabolism of injury. First phase is our ebb phase. It is the first phase which is occurring in the 24 to 40 hours after injury, and it is basically characterized by hypovolemia, decreased metabolic rate, decreased cardiac output, hypothermia and lactic acidosis. So basically this phase is carried by predominantly hormones such as catecholamines, cortisol and aldosterone. This is also known as our cocktail regimen of catecholamines, cortisol and aldosterone, and also some percent of a antidiuretic hormone. So what is the main role of this F phase is it acts as to conserve energy and maintain perfusion to vital organs. So basically this phase conserve energy as much as possible, so that during the next phase it can utilize for tissue repair and tissue buildup. So this phase is followed by our hypermetabolic flow phase, which is our catabolic phase. So which is also associated with systemic inflammatory response syndrome. So this is the F phase. So in the next phase, that is our hypermetabolic flow phase. This is characterized by hypermetabolism, increased oxygen consumption, increased cardiac output, increased tachycardia, fever, and also hyperglycemia, because patient will be having peripheral insulin resistance. So also our cocktail regimen such as catecholamine, cortisol, glucagon is also increased in this phase. So basically, patient will be having, due to excess of buildup, excess of protein catabolism, patient will be having negative nitrogen balance, lipolysis, and lots of gluconeogenesis is happening. Basically, the tissue repair will repair from the proteins. So proteins are derived from our, predominantly from our peripheral skeletal muscle proteins, and this leads to weight loss. And also there are multiple acute phase reactor protein which are produced by liver such as CRP, it increases. So suppose if this catabolic or hypermetabolic flow phase is prolonged, there is a delayed wound healing if it is a prolonged. So basically patient will be having excessive metabolism in this phase, so that it wants to get rid of this inflammatory phase and restore the body energy as soon as possible. Excuse me. So to overcome or to compensate or to suppress the excessive inflammatory reaction in the body, there are various innate immunity system, and these are the multiple immunity systems are available. First ones are our body's natural antagonists such as interleukin 1 receptor antagonist, TNF alpha receptor antagonist such as TNF SR 55, and this is 75. So this is the MCQ point, that is TNF alpha receptor, soluble receptor 55 and 75, not some 65. So other factors such as interleukin 4, interleukin 5, interleukin 9, interleukin 13, and transforming growth factor beta is also involved in controlling this excessive inflammation. And also there are specialized pro-resolving mediators such as lipoxin, protectins, and marcins. So these are our anti-inflammatory body's receptors and specialized pro-resolving mediators. So if this anti-inflammation response continues, body goes into compensated anti-inflammatory response syndrome, that is called as our CARS. So prolonged anti-inflammation is also not good, because if prolonged anti-inflammation, it leads to patient into the continuous immunosuppressed state, that is called as PICS, that is persistent inflammation is also going, and our patient is also having immunosuppressed state. In this state, patient will be more prone for infection and more prone for sepsis. So prolonging any stage, either it is a catabolic state or hypermetabolism state, is bad to the patient, and it depends on the severity of injury, severity of trauma, state of shock, and also how the genetic capacity of the patient also important, because majority of surgery we are doing routine days, but how that each patient differ, or how the each patient's body react to our surgery, it differs in the each individual because of its genetic makeup. So coming to our next, energy expenditure after trauma. So we have seen the graph in the beginning. So normal resting energy expenditure in normal patient is up to 10 to 15%. So whenever the patient is having any kind of major trauma, the resting basic energy expenditure will increase up to 15 to 25%. So in exception of major burns or exception of major sepsis, where energy expenditure can reach up to 50 to 100%. So patient will be having severe hypermetabolism in this stage, but in most of the trauma patient will be having energy expenditure of 15 to 25% per day. This is also one of the MCQ point. So why this, knowing this much of energy expenditure is important, because while calculating energy deficit, or while calculating energy deficit which is required to the patient of trauma patient or burns or sepsis patient, we should keep in mind this much energy expenditure is needed, and we have to correct this much energy expenditure, or else patient will undergo into the cachexic state. So basically, why we keep the patient into the ICU or severe intensive care unit? So because we have to keep this basic metabolic rate into control level. So how we can keep the patient into the control level? Basically, whenever if the patient is having excessive respiration, whenever the patient is having irritability, we can sedate the patient by using neuromuscular blockade. And also in the patient is in ICU, patient is in the bed rest. If the patient is having excessive breathing, if the patient is having lots of tachypnea, usage of accessory muscle, we can intubate the patient and we can sedate the patient so that it will reduce the basic metabolic expenditure. Also in the ICU setup, we will be keeping the patient into the normothermia so that enzymes will be in the check and also body's temperature is normal so that hypermetabolism state is controlled. And also patient will be in the paralyzed state so that these all the measures to keep the hypermetabolism state in the check. So basically in the trauma, energy expenditure will increase up to 15 to 25%, and remember that burns are having highest metabolic response up to 50 to 100%, and we are keeping the patient ICU just for the sake to control this hypermetabolic state into the normal level. So basically what is this metabolic response to injury, why we are giving this much important to this metabolic response to injury? Because nowadays we are having all the equipments, nowadays we are having all the protocols in the trauma, so that in the developed countries most common cause of death after resuscitating the patient and after in the early days post trauma is due to exaggerated over inflammatory response syndrome, and that leads to multiple organ dysfunction and death. So that's why we are modern perioperative care revolves around controlling this hypermetabolism state into the check. So how we can keep the hypermetabolism state or exaggerated response inflammatory syndrome into the check is by performing our minimal invasive surgeries and also effective pain control. We can keep if we are operating for any kind of major supra major open surgery, we can keep the patient into epidural anesthesia so that in the post-op also through the epidural catheter we can infuse our painkillers. And also we can start the patient early enteral nutrition so that patient should not go into the under metabolism or under nutrition state. And also we should not excessive infuse the patient with the fluids so that patient will be having post-operative ARDS, patient will be having post-operative peripheral edema, so that we should maintain the goal directed fluid therapy. And also patient should not be hypo or hyperthermic state so that we maintain the normal temperature of the patient. So to keep everything in the protocol and systemic way, nowadays we are using this protocol that is called as enhanced recovery after surgery protocol, that is our ERAS protocol. So this protocol revolves around the modern perioperative care pathology. So there are multiple components in the ERAS protocol, but most of these ERAS protocols are used in the modern perioperative care. So as we discussed, in developed countries most common cause of death after major injury is because of our exaggerated severe inflammatory response system or systemic inflammatory response syndrome that leads to MODS and that leads to death in the majority of the developed countries. So basically whenever this systemic inflammatory response syndrome is happening, it is initially sterile. So once patient immunity will go into the lower level or once patient is immunosuppressed, the patient's inflammatory response system which was initially sterile, it later become infected and leads to formation of sepsis. And remember one thing, multi-organ dysfunction syndrome, it is having a mortality of up to 25%. So this is also one of the MCQs. So basically the response is graded, that is if there is a minor trauma, there is a minor response. If there is a major trauma, if there is a major sepsis, the response is severe graded. So whenever you can think in the normal post-operative patient, suppose if you are operated any case of Whipple surgery or any case of hemicolectomy or any abdominal perineal resection, post-operative in the day 1 or day 2 or patient will be having leukocytosis, patient will be having increased temperature, patient will be having tachycardia, patient will be having tachypnea. So if the patient is having within day 1 or day 2, you don't need to do anything, you have to just wait because the patient will be in the state of systemic inflammatory response syndrome. So you have to just wait and you have to think what is happening with the patient, and if there are any secondary triggers or if there are any ongoing infection, ongoing hemorrhage or ongoing sepsis, so you have to correct the underlying problem so that this systemic inflammatory response syndrome which is there in the post-operative day 1 or day 2, it should not get exaggerated in the next days. So basically how this, what is this mechanism. So whenever there is a tissue injury, suppose if you are having road traffic accident, if there is a if there is a crush injury of lower limbs, so whenever there is a crush injury, so there are damage associated molecular proteins. So these damage associate, so suppose this is your tissue, and if there is any injury to this tissue, so there is a release of multiple damage associated molecular proteins from the tissue. So this is the basically innate immunity, and it is a protective mechanism. So damage associated molecular proteins are such as heat shock proteins, HMGB1, S100 proteins. This is also called as alarmins. So whenever there is a tissue injury, there are release of multiple damage associated molecular proteins. So this damage associated molecular proteins are recognized by pattern recognized receptors. Such these are the toll like receptors and nod like receptors. So where are these pattern recognition receptors are present? So these are present over the macrophage and dendritic cells. So this is our damage associated molecular proteins, and damage associated molecular proteins are sequenced or sensed by our pattern recognition receptors, which are present over the macrophages. So these are the same types of innate immunity. So this get activated and it forms complex with our damage associated molecular proteins, leads to formation of inflammasomes. So these inflammasomes activate caspases. So caspases are enzymes. So basically caspase, what will happen, caspases are enzymes which activate multiple interleukins and multiple cytokines. So predominant interleukins are interleukin 1, interleukin 6 and TNF alpha. So interleukin 1, interleukin 6 and TNF alpha are chemokines. What these interleukins will leads to? It leads to release of more damage associated molecular proteins and leads to reactivation, and again this cycle will continues to form relation of systemic inflammatory response syndrome, that is our SIRS. So whenever there is a severe SIRS is happening, cell death will happen, tissue injury will happen, and immunosuppression state will happen whenever there is a exaggerated systemic inflammatory response syndrome. So it acts as a positive mechanism or vicious cycle. So this is the how the mechanism of tissue injury, and this damage associated molecular proteins named such as heat shock proteins, HMGB1, S100 proteins. So these are the frequent our MCQ point in NEET super specialty examination. And also the important interleukins are interleukin 1, interleukin 6 and TNF alpha. So these are our frequent asked MCQ points. So there is also along with our release of damage associated molecular proteins, our basically our neurohumoral response also keeps in action. So how our neurohumoral response keeps in action, this is the flow chart taken from the belly. So whenever there is a any kind of tissue injury, so what will happen in any kind of tissue injury, the pain fibers are carried by our nociceptive fibers. So whenever there is any kind of injury, afferent nociceptive pathway is carried by our pain pathway. So whenever there is any injury is happening, so it is basically it is carried by, first is by our pain pathway, that is carried by. So whenever there is any kind of metabolic response to injury, so it starts by our neurohumoral response also. So how this neurohumoral response will happen, so whenever there is any kind of injury or any kind of major surgery, so patient will be having some kind of pain. So this pain is activated by our afferent nociceptive stimulus, and it will nociceptive stimulus is carried through our spinal cord, and it will go and it will stimulate our hypothalamus, because hypothalamus is our majority of things are happening in the hypothalamus. So what hypothalamus will cause, hypothalamus will release our ACTH and also our growth hormones. So what this ACTH will go and act, so basically ACTH will go and acts on our adrenal glands. So it will release the catecholamines, predominantly our adrenaline, and also it releases from the cortisol. So basically adrenaline and cortisol levels will increase. So whenever there is a adrenaline cortisol level will increase, and also because of activation of sympathetic nervous system, so it will go and act on the pancreas, so that glucagon synthesis is also increasing. So basically what these adrenaline, cortisol or glucagon. This main role is to inhibit the action of insulin, so that body is having state of our hyperglycemia, so that that glucose is utilized for tissue injury, tissue repair, or any kind of inflammation activities. So basically this state, it leads to the state of insulin resistance, where the insulin is produced by the body, but insulin is not recognized by peripheral insulin receptors, so that insulin is the higher level, but the insulin receptors are not recognizing it, so that the glucose is not utilized by cells and glucose is used by some kind of tissue injury or some kind of tissue repair. So whatever these neuroimmunity response is happening, it leads to formation of adipocyte lipolysis. It leads to formation of hepatic gluconeogenesis, lots of glucose is secreting. It leads to skeletal muscle protein degradation, so that proteins, end product of proteins used for gluconeogenesis in the liver, also production of more of C-reactive proteins such as acute phase hepatic proteins, and it also leads to pyrexia and state of hypermetabolism. But remember only one point along this state. So this state is leading to the anti-insulin action. So normally there is normal muscle protein turnover rate in the normal individual is 1 to 2% of per day. But whenever there is any kind of major injury or any kind of major trauma, this muscle protein turnover rate will increase, and there is a lots of protein is needed in the patient for wound healing and repair. So from where these proteins will derived? So proteins will derive from our peripheral skeletal muscle proteins. So skeletal muscle peripheral protein is derived, so that patient will be having kind of myopathy state, and also muscle proteins are derived from our respiratory muscle, so that patient will be not able to breathe properly and patient will depends on our ventilator setup, and also patient will be having usage of our abdomen muscles, so that patient will be having reduced gut motility. And remember only one neat important question is that our cardiac muscles are predominantly spared in this action, because these are our predominantly smooth muscle. Rest of all the skeletal muscles are involved. So how this protein metabolism or skeletal muscle protein metabolism is involved? It is happening majority of through enzymatic degradation by ATP dependent ubiquitin proteasome pathway. So this is also one of the MCQ's important point. So ATP dependent ubiquitin proteasome pathways involved majority, and rest pathway is lysosomal cathepsin and also calcium calpain pathway. And normally, as I told in the beginning, the normal urinary nitrogen excretion rate is up to 10 to 14 grams. But if the urinary nitrogen loss in cases of severe sepsis and severe trauma, it may increase up to 14 to 20 grams per day, which is approximately equal to our 500 grams of skeletal muscle loss per day. Just remember, if there is 500 grams of skeletal muscle loss per day is happening in your patient, and you are not providing the same amount of protein to the patient, it will lead to the myopathy, and patient will be having state of immunosuppression. So this whole term is called as critical illness of myopathy. It is characterized by muscle wasting, weakness, ventilatory dependence. So also there is a alterations in hepatic protein metabolism. So remember one thing, basically most of our protein in the body is made up of, either it could be from liver derivative or it could be derivative of skeletal muscle protein. But remember one thing, even though skeletal muscle protein is the more compared to our liver mass, but it is having low turnover rate of up to 1 to 2% per day. But our liver is small compared to the peripheral skeletal muscle, but it is having high turnover rate of 10 to 20% per day. But in the liver, majority in the hepatic protein synthesis is in the 50-50% state. What is this 50-50% state? That it leads to formation of structural proteins, these are the 50%, and also export proteins such as these are the 50%. So liver forms 50% of structural proteins which are required for our skeletal muscle formation or any kind of body buildup, and also export proteins which are involved in the transport mechanism such as albumin. And major export protein is our albumin. So basically albumin synthesis rate is almost 10% of our all the protein synthesis per day. But albumin synthesis is 10% per day, but also albumin is having transcapillary leak of approximately, which is approximately 10 times of synthesis rate. So that's why this trans capillary escape rate is important, because whenever there is injury or whenever there is any kind of sepsis, our capillaries are leaky. So in that aspect, this trans capillary escape of albumin, which is normally happening 10 times of synthesis rate, it will increase more, and patient will be having state of hypoalbuminemia. So whenever you are having any major trauma or a sepsis, don't think the patient is in the hypoalbuminemia state because of pre-insult. Patient might be having hypoalbuminemia because of increased transcapillary escape rate, which is happening because of your severe inflammation. So this is predominantly happening in the albumin. And also there is a interleukin 6, which is the stimulation for acute phase reactants produced from the liver. So there are positive acute phase reactants such as C reactive proteins, and also fibrinogen, and also ferritin, and haptoglobin, serum amyloid A, and there are negative acute phase reactants. So this is the most favorite question, which is the positive acute phase reactant, which is the negative acute phase reactant. So our C reactive protein is the acute phase reactant protein, whereas albumin is also our negative acute phase reactant protein, and other negative acute phase reactant proteins are transferrin and pre-albumin also, that is called as transthyretin. So as I discussed in the beginning, this hypermetabolism state, body is in the state of insulin resistance, predominantly mediated by IL-1, IL-6, and our TNF alpha TNF alpha leucines. So this severity is proportional to our magnitude of injury, that is our graded response. Suppose if there is any upper abdominal major surgery, such as if there is any kind of pre-pylori perforation, patient underwent perforation repair or Grams repair. So patient might land up in case of insulin resistance, that might. Coming to normal protein metabolism, the normal labile energy reserve of the body is our fat. So whenever there is any energy requirement, fat is the first product which is going to be metabolized. So what is the main labile protein reserve is our any kind of peripheral skeletal muscle proteins. So 1 gram of nitrogen is equal to our 6.25 gram of protein, which is equal to 36 gram of wet tissue. So normal protein turnover is 150 to 200 gram per day, and normal protein intake is only 70 to 100 gram per day, and end product of our protein metabolism our ammonia and urea. So normal urinary nitrogen excretion is over 14 gram of per day, but in the cases of starvation, adaptive ketogenesis will happen, and it will prevent the more loss of our nitrogen from the urine. So it will prevent the nitrogen losses from the urine. But this adaptive ketogenesis, it is not happening in the major sepsis or majority of trauma patient. In that, urinary nitrogen losses will loss from the normal 14 to up to 20 grams per day. So in, as I told, which is equivalent to up to nitrogen loss up to 20 grams per day is equivalent to up to 500 gram of lean body mass per day. So the critical protein loss is 30 to 40% of total body protein mass. So whenever there is a protein loss is more than 30 to 40% of body mass, survival is unlikely in such cases. And whenever there is any kind of major injury, major trauma, so there are some changes are happening in the body composition also in the post-operative patients also. Suppose if you operated any supra major surgeries, in the post-operative day 1 or day 2, patient might increase or gain weight because of your systemic inflammatory response syndrome, because of your edema, because of your perioperative more infusion of fluids. It leads to increase in the edema. But after that, in the next 10 days, there is a loss of up to 15% of body weight, which is happening in the next 10 days. So you have to keep in the mind how much patient is losing the weight. For that, you have to daily measure the weight whenever the patient in the ICU, so that you have to think whether the patient is land up in the any kind of third space loss of fluids because of your systemic inflammatory response syndrome. So how to reduce this severe protein loss is by careful intraoperative fluid balance, so that it should not exaggerate systemic inflammatory response syndrome. Early oral or any kind of enteral or any kind of TPN feeding you should be started to the patient after 48 to 72 hours, and epidural analgesia or any kind of anesthesia is important, and also you have to be in the ERAS protocols for in the perioperative period. So this is the flowchart showing the how the protein or skeletal muscle protein metabolism is happening. So basically, whenever there is a any kind of injury, it will leads to activation of our caspases and cathepsin and calpain enzyme. So basically these are E1, E2, E3 such as ubiquitin conjugates, ubiquitin ligase, ubiquitin degrades. So these are the mainly ubiquitin proteasome pathway. So this what this ubiquitinate proteins, it will start easily degrading by our enzyme system in the body. So whenever the ubiquitin get ligated with the skeletal muscle protein, so it gets degraded easily and it leads to formation of our oligopeptides and amino acids are released in the circulation. So this E1, E2, E3, these are the ubiquitin enzymes. These enzymes are asked frequently in the NEET super specialty examination. So there are some factors which are the avoidable factors which can we can avoid during our most of the time avoidable factors, which are these are the factors we can avoid during our systemic inflammatory response syndrome. So what are these avoidable factors? Such as volume loss. So if there is any kind of volume loss, hypovolemia, it will increase ADH or aldosterone. So what this ADH or aldosterone, it leads to retention of fluids in the body and also retention of your any kind of solutes in the body also. Suppose if you are in the post-operative patient, if your patient is already in the oliguric state and patient is already in the salt retention state, and you are in the perioperative period, if you are infusing the patient with lots of hypertonic saline or lots of normal saline, patient will again lose the fluid in the third space and will start accumulating in the body. So that patient will be having peripheral edema, visceral edema. It leads to delayed gastric emptying, and also patient is having anastomotic site edema, leads to anastomotic failure and leakage. So that's why perioperative fluid management is very much important. And also second factor is hypothermia. So whenever there is hypothermia, it will stimulate the sympathetic nervous system. Catecholamines, aldosterone and cortisol is again stimulated. So remember, whenever there is a mild hypothermia also, there is a 2 to 3% chances of increase in the postoperative cardiac arrhythmias, and it increases the catabolism as mentioned in the multiple randomized controlled trials, and it leads to formation of wound infection, cardiac complications, bleeding, and blood transfusion requirements will increase because of your smaller hypothermia. So maintaining normal temperature in the intraoperative and postoperative period is also very much important. So there are other triggers of inflammatory pathway. These are the sepsis, hemorrhage. If you are a transfusing patient for massive transfusion protocol because of your severe hypovolemic shock, if the patient is having acidosis, patient having any kind of surgery in the in the initial period of your severe metabolic response syndrome, and also crush syndrome or any kind of ischemic reperfusion injury, this will activate more secondary triggers of your metabolic response to injury. Third one is our tissue edema because of excessive IV fluids, or because of your systemic inflammatory response syndrome, your capillaries are more in the leakier state. So whenever the capillaries are also leaky and you're infusing the patient with lots of fluid, so as I told in the beginning, the transcapillary rate of albumin will increase. So this leads to again also tissue edema, delayed wound healing, and anastomotic failure. And also patient will be having paralytic LVS, and also patient develops acute respiratory distress syndrome. So fourth, our metabolic secondary triggers are systemic inflammation and tissue underperfusion. So whenever there is a, so basically our capillaries, endothelium, these are the important checkpoint, and because of these only the perfusion happening, nutrition is transporting to the vessels, and also nutrition is transporting everywhere in the body, and blood supply is also happening through our capillaries. So whenever there is a whenever there is excessive activation of systemic inflammatory response syndrome, either could be because of hyperglycemia or because of sepsis, it will activate our inducible nitric oxide synthesis enzyme. It will lead to degradation of nitric oxide, so that tissue will, nitric oxide is a vasodilator. If there is a degradation of nitric oxide, tissue will undergo in the vasoconstriction or hypoperfusion state. It leads to acute kidney injury, acute lung injury, any, and multiple organ dysfunction syndrome. So that's why keeping the sepsis or any kind of hyperglycemia check is also important in the post-operative period. So remember one thing, Whenever there is a starvation, normal brain requires up to 100 grams of per day. So during the first 24 hours, glucose supply to the brain is happening by liver glycogenolysis. But what happens after 24 hours? Hepatic gluconeogenesis will happen from multiple sources such as amino acids, glycerols and lactate and other tissues. Mainly fat is the labile source of energy. So hence fat is also mobilized, and liver converts whatever fat is getting to the liver convert into the due to anaerobic metabolism, and ketone bodies formation will happen, and these ketone bodies can be utilized by our brains also. So whenever there is excessive ketone bodies happening, skeletal muscle degradation is also rapidly happening in the body. So to avoid this unnecessary fasting, we can start early feeding. And also there is a recent anesthesia guidelines that up to two for any kind of liquid diet or fluids, up to 2 hour NBM is enough. And also during perioperative period, we can infuse to the patient or ask the patient to drink the carbohydrate rich food, rich any kind of supplement, so that patient should not land up in the post of hypoglycemia. So fourth factor is also immobility. Why this immobility is important? Whenever the patient is bedridden, patient is not using the skeletal muscles. So this immobility also leads to decreased responsiveness of our whatever proteins we are consuming. The response and production of amino acid, these proteins also decrease because of immobility. This results in negative nitrogen balance and loss of lean body mass. So hence to prevent this, there is early mobilization in the post-operative period, and also avoid the unnecessary bed rest to the patient. And also if the patient is very much weaker, not able to do workup anything, pre-operative rehabilitation of the patient is also very much important. And this around the perioperative care revolves around our enhanced recovery after surgery protocols. So what are these protocols goals are: prevent unnecessary surgical stress to the patient, avoid prolonged fasting, avoid excessive fluids to the patient. And what is the benefits of giving ERAS protocols or using ERAS protocols? It decreases hospital stay by 30 to 50%, and there are lots of faster recovery happening in the patient, and it also decreases our post-operative complications. What are the components of ERAS? Minimally invasive surgery. We can, if there is a hypersympathetic activity, it is only theoretical, but we can use the beta blockers to attenuate the hypersympathetic activity. We can use the epidural anesthesia, especially in open surgery, no role in the laparoscopic surgery, and we should use the patient controlled analgesia. Single shot spinal dimorphin injection we can use, or IV lidocaine infusion we can use, so that we can spare the opioids. And also this ERAS protocol will improves, it improves our gut function, it enhances the recovery. And also we have to give the early oral feeding, early mobilization, minimal perioperative fasting, and goal directed fluid therapy by avoiding the fluid overload. So what are the, so these are the protocols of ERAS or components of ERAS. So we can remember by mnemonic: fast track, F for fluid optimization, A for analgesia, that is patient centered, S shorter fastings, T timely feedings, T tubes or any kind of drain by minimal usage, and R for rapid mobilization to the patient, A for anesthesia, epidural anesthesia for open surgery, or any kind of spinal infusion of lidocaine or single shot of dimorphine for any kind of minimal invasive surgeries. And carbohydrate loading is important perioperative period, and K for keep hospital stay short by 30 to 50%. So this is the all the important aspects of ERAS protocol, and these are the some of the important topics given in the Balian law for tissue injury and metabolic response to stress. So this is the chapter covered from the Balian law, first chapter, metabolic response to injury. So in the further sessions we'll be keeping the next topics from the Balian law. Thank you. Hmm? Please follow our Instagram channel and also our YouTube channel for further any videos or any kind of queries, and please DM us for